Yeah, so directly starting my topic, that is a newer approach to a patient with a diabetic chronic kidney disease patient. So while we are talking about this topic, diabetes and chronic kidney disease, this can be very well explained by this excellent study which was published in Kidney International that shows that a similar patient who is having diabetes, if he develops chronic kidney disease, chances of mortality because of cardiac event would be doubled, and development of end-stage renal disease would be almost 6 times higher. So that is why it is a fearsome combination to have diabetes and chronic kidney disease. So because of that, we have evolved across years for that treatment of diabetes and chronic kidney disease. And recently, as you must have been practicing SGLT2 receptor inhibitor, particularly dapagliflozin, and then now newer molecule, that is finerenone, which is more organ-specific approach that we are going to see today. So this is the current situation of diabetes in India. Almost 77 million population in India is suffering from diabetes, and out of them, almost 48% are having some form of chronic kidney disease. But the fearsome statement is this: despite adequate glycemic and blood pressure control, almost more than 30% of this population will progress to develop chronic kidney disease. So this is really fearsome. And this also indicates that we are missing certain things or certain therapy in patients of diabetes as well as kidney disease. So let us understand this by a case. This is a 52 years old gentleman who is suffering from diabetes for long duration, almost type 2 diabetes, for almost 12 years. And he is otherwise under good glycemic control with HbA1c of 6.8 and good blood pressure control with ACE inhibitors. In follow-up visit, he is showing gradual progression of proteinuria and fall in GFR. So why we are worried about this? Because whenever there is a rise in proteinuria, there will be gradual fall in GFR. So proteinuria is a predictable factor for progression of the chronic kidney disease or kidney dysfunction. So as can be seen, whenever there is a rise in proteinuria, there will be fall in GFR, and whenever there is a proteinuria, there is associated rise in cardiovascular mortality. As can be seen, even with normal GFR, if patient develops proteinuria, cardiovascular events would be on a higher side. So that is why not only estimated GFR or creatinine is the only indicators of development of progression of CKD or cardiovascular events, and that is why all guidelines are recommending measurement of albumin-create ratio or proteinuria in the group of patients. So as can be seen, recommended treatment by ADA for type 2 diabetic CKD patients is RAS inhibition, that is ACE inhibitor or ARBs. But even this is a landmark trial, that is a renal trial, that suggests that despite 16% risk reduction with this group of patients, 40 to 44% will progress to chronic kidney disease, and not only progression of the chronic kidney disease, but there will be associated progression or development of new cardiovascular event. So this gray area of residual risk is always there with this group of patients. This is again landmark trial, DAPA-CKD trial, which was prematurely discontinued. Here all the patients were on RAS inhibition, and all of them were receiving dapagliflozin in a study arm. So this was discontinued because there was a significant improvement in the treatment group of arm. So it was for beneficial effect. Trial was terminated, and it was recommended that this type 2 diabetic CKD patients should be on RAS inhibition with SGLT2 inhibition. But again here, it was seen that residual risk for cardiovascular event as well as progression of chronic kidney disease is still there. And it is not only because of drug-specific effect of dapagliflozin, it can be with any SGLT2 inhibitor. So there is always residual risk with usage of this medication. And not only progression of chronic kidney disease, but cardiovascular event too. So are we missing something? Studies have shown there is a third driver of progression of the chronic kidney disease, other than hemodynamic and metabolic control, which we are treating as of now. And this driver is inflammation and fibrosis. And why this is happening? It has seen that whenever there is a state of chronic kidney disease or congestive cardiac failure, there mineral receptor activation, which is in multiple fold by multiple mechanisms. And this mineral receptor activation will ultimately lead to inflammation and fibrosis, and that will lead to cardiac remodeling as well as progression of chronic kidney disease. So if we treat, apart from hemodynamic and metabolic control, inflammation and fibrosis, then it can be a newer therapeutic approach, and here we are targeting. So newer molecule called finerenone, which is a novel non-steroidal selective mineralocorticoid receptor antagonist, is now available, and it has been approved by DCGI in India. It is available in India since August 2022. Commercially it is available for type 2 diabetic CKD patients. So once it binds to mineralocorticoid receptor, it will cause conformational changes in the receptor, and that receptor will not be available for its function for almost 24 hours. So this drug is having effect for 24 hours. And it will inhibit inflammation and fibrosis subsequently. So this is a third generation mineralocorticoid receptor antagonist after spironolactone and then subsequently finerenone. So it is the only molecule which is indicated in type 2 diabetes CKD patient. If we compare, it is equally potent to spironolactone, but it is more selective. And because it is selective, it is having lesser gynecomastia effect or steroidal side effects. It does not cross CNS blood-brain barrier, and that is why there is least effect on blood pressure. It is having very short half-life, and there is no active metabolite. And that is why whenever there is a side effect, that is hyperkalemia that we are seeing with spironolactone, just by discontinuation of this medication for a few days, you will achieve control of this hyperkalemia. So what are evidences this medication is effective in this group of patients? So there are two phase 3 clinical trials, Fidelio and Figaro. But we are not going to go into depth of this trial, but there is a pooled analysis called Fidelity, and that has studied 13,000 patients. That is, I suppose, maximum possible evidence for any molecule in this type of diabetic CKD patient. So here study was done of effect of finerenone in type 2 diabetic CKD patients for their cardiovascular as well as kidney composite outcome. Patient characters, they were having GFR of more than 25 and proteinuria more than 30 mg per gram. So they were having moderate to severe dysfunction or moderate to severe proteinuria and say stage up to stage 4 CKD. All of them were having long-standing diabetes, but otherwise very well controlled, and every one of them were on ACE inhibitor or ARBs, not necessarily SGLT2 receptor inhibitors. So what it showed, that there is a positive effect of finerenone in cardiovascular composite outcome, and it reduces cardiovascular events by 14%. But more striking is this green arrow in Figaro trial, that is 29% reduction in hospitalization due to heart failure. Similarly, there was improvement in renal outcome by 23%, but most striking is 36% reduction in development of end-stage disease. So in your patients in a clinic, with those who are having diabetes with associated proteinuria, and if you are treating them well with ACE inhibitors and with medication, any kind of oral hypoglycemic agent or insulin, if patient is having persistent proteinuria or deterioration of GFR, this is the indication of starting finerenone, and that by doing that you are reducing chances of development of end-stage renal disease by almost 40%. And this reduction of proteinuria was how much? That is almost 32% compared to baseline. And this reduction in proteinuria starts after 4 months of therapy, and that will be sustained. So this is efficacy. What is about its safety? So it has been seen that overall safety in form of adverse event or serious adverse event were equivalent to those who are on placebo group. Development of gynecomastia was almost nil, and there was say moderate effect on blood pressure up to 3 to 4 millimeter fall in blood pressure, and no effect on diabetes control. Severe form of side effect or single significant side effect marked was hyperkalemia, but hyperkalemia requiring treatment discontinuation was insignificant, and there was a zero death observed because of hyperkalemia in this 13,000 patients across 3 years. So because of that, now all of guidelines are recommending this molecule as a level A recommendation for type 2 diabetes CKD patients. So as I have said, it is available now in India and approved by DCGI. This for type 2 diabetic CKD patients for prevention of progression of chronic kidney disease as well as cardiovascular event development. So whom should be initiated? Which are ideal patients? So as we have discussed and as now KDO is saying that first parameter is to control lifestyle, then followed by you control diabetes and blood pressure well. Even after that, if there is persistent proteinuria when ACE inhibitor or ARBs are on board, if patient is still having proteinuria or persistent deterioration of kidney function, then there is a role. So KDO suggests position of finerenone after treatment of RAS inhibition. So again coming back to our case, it is showing now gradual progression of proteinuria or rise in creatinine. So his GFR is falling. So should we start him on finerenone therapy? Yes, because we have adequately controlled his diabetes, we have adequately controlled his blood pressure with ACE inhibitors, but still patient is showing progression of the disease, kidney disease. So he was started on finerenone to prevent further deterioration. So in what dose we should start this patient? There are two power of medication which is available in market, that is a finerenone 10 mg and 20 mg. So whenever you are starting this molecule in your patient, you have to first do potassium measurement as well as estimated GFR. So if patient is having potassium less than 5, then you are starting this medication. Then it depends on GFR. If GFR is less than 25, you are not starting. But if GFR is more than 25, but less than 60, 10 mg, and more than 60, you can go up to maximum dose, that is 20 mg. So here this potassium is 4.3 and GFR is 65. So we started him directly on 20 mg. And then how to follow up this patient? After 1 month we check his potassium. If potassium is still less than 5, we can continue with 20 mg. But if it is more than 5.5, we have to stop. Similarly, another case, but more severe proteinuria and more advanced CKD, stage 3, stage 4. Same adequately controlled sugar and blood pressure, now showing progression, started on finerenone. What dose we should start? His GFR is less than 60 but more than 25, so we should be started on 10 mg as we have controlled potassium. So again, if you do his potassium and follow, if it is still less than 5.5, you can increase the dose from 10 to 20 mg. But if it is more than 5, you are stopping it. So what are actual contraindication of giving this molecule? When GFR is less than 25, you are not starting this molecule. If patient is already on finerenone, and when in that situation, if GFR falls below 15, you stop it. It is hepatic. It is having hepatic metabolism. So whenever there is a severe hepatic dysfunction, you will not start this molecule or you discontinue. Whenever there is additions crisis, as it is affecting adrenal, so we are not using this. And anyone who is on CYP3A4 inductor or inhibitor, you are not using this. Another molecule still not having any major experience as of now in our market, recently launched, is imaging. I'm going to just touch it superficially. It is a newer group of oral hypoglycemic agent, glimmin group, and it is approved in Japan and now available commercially in India. So its effect is, it is more or less type of metformin effect. It increases insulin sensitivity, decreases neoglucogenesis, increases beta cell function, increases mitochondrial function, and decreases oxidative stress. It has seen in kidney, it improves mitochondrial function and density, and that is why it decreases proteinuria and fibrosis. So dose 500 mg BD, but if GFR is less than 15, you cannot use metformin, but here you can use this molecule whenever GFR is less than 15. So in CKD stage 5 you can use this molecule with OD dose, 500 dose. So imaging can be used up to GFR less than 15 ml per minute. And why to consider? In CKD, it reduces the risk of lactic acidosis, which is quite common with metformin after stage 3. So you are not using metformin when GFR is less than 30 after stage 4. And may improve kidney interstitial fibrosis. Can be used with any oral hypoglycemic agent in combination. So with that, I suppose I am resting my presentation, but there are certain question and answer. If you wish, you can answer just to improvise our knowledge about finerenone. So, what is approved indication of using finerenone? A. Proteinuria illness with chronic kidney disease. Diabetic proteinuria illness with chronic kidney disease. C. Cardiorenal syndrome in ICU patient. And D. All of above. Okay, great. Perfect. So, on treatment, if potassium is more than 5.5, I will discontinue finerenone first. I will discontinue ACE inhibitor or ARB first. I will continue both and add anti-caloric therapy first, or I will discontinue D.
I will discontinue.
This for C?
Yeah.
C. Will discontinue treatment.
Wait, then take it, right? C.
Okay, C. Anyone for D?
D.
Actually, answer is D. You have to discontinue both. And then you start with ACE inhibitor or ARBs first. Later on, you can start with finerenone with lesser dose or titrating. When potassium is less than 5. Can I start finerenone without ACE inhibitor or ARBs? Yes or no?
Yes. No. Yes. No.
Yes. Answer is no. So first of all, patient has to be there on adequate dose of ACE inhibitor or ARBs. And can I start finerenone without a SGLT2 receptor inhibitor?
Yes.
Dapagliflozin or any? Yes. Answer is yes. Thank you.
Good evening all. Thank you very much for giving me this opportunity. When the first talk started at 8 a.m. and it is 8 p.m. after 12 hours, how much should I speak is really a great dilemma rather than selecting the fluid for resuscitation. But I think that I will try to speak some of the very practical aspects and something which can provide you take-home message easily. See, it's an important intervention, especially in emergency, and therefore our right decision makes the sense. Even in studies like London, in NICE guidelines, they say that it's 20% wrong prescription of the fluid. And one of the very recent 2020 paper says that amongst physicians, this talk is not taught and therefore ignorance is common. So let me talk to you something very day-to-day problem. Let's suppose patient presents to us in ICU with 70 years and blood pressure is 70 and patient is hypovolemic, febrile. How should we treat it? Now, we have lot many fluids available to us and therefore what to select? What is the right kind of the fluid selection? Is a dilemma. So, which solution should be used for resuscitation and why? To explain it, I would like to have discussion in 3 different headings. First, physiological basis. Then we will have crystalloid, colloid, and then colloid, crystalloid, then ritual. So, physiological basis is that 5% crystalloids, colloids. Why the effect differs? Answer is that it's because of the distribution. If we give fluid like 5% dextrose, it gets distributed in all compartments equally, and therefore out of 1 liter, hardly 83 ml will be retained inside the intravascular compartment, and therefore its ability to raise the blood pressure will be very, very poor. Against that, if we select fluid like saline or regus-lactic, because it is sodium containing and sodium distributes only in ECF compartment, it will get exclusively distributed in ECF, and therefore expansion in the intravascular compartment will be roughly around 250 to 300 ml. And the last one, colloidal blood products are most potent because they are distributed entirely in intravascular compartment. Whatever volume you distribute, will infuse, will expand the blood pressure, will expand the intravascular compartment. Not only that, the fluid like 20% albumin, hypertonic fluid, will expand even greater than what is infused, and therefore selecting the right kind of the fluid. All this physiological basis has a great importance. Now, when we say that colloids are potent and crystalloids are good, the question arises that which one should we use? There is a great debate, lot many literature, lot many studies. So today I am going to have evidence-based discussion. We have 4 players with us for this marathon: saline, balanced fluid, albumin, and hydroxyethyl starch. First, let us have a fighting between potent colloid and poor crystalloid. So which one is better? Obviously, on physiological basis, colloids are greater, faster, longer, potent. But is it better? So efficiency-wise, yes. But safety, adverse effect, outcome, and studies, what does it say? So we will have albumin versus crystalloid first. 2 important trials: 2004 SAFE trial, 2014 Albios trial. In these both trials, they say that whatever agent you use, there is no difference in mortality at 28 to 90 days, and therefore the conclusion is that current guideline cannot endorse the use of albumin in light of its expense and lack of proven benefit. So whether you give crystalloid or albumin, they are aligned. But then does it mean that albumin has no role? Should we discard albumin? No. Albumin should be used as a second line agent for fluid resuscitation. When should we use it? Selectively in patients who do not respond to crystalloid, who cannot tolerate large volume of crystalloid, and therefore, in those patients who have severe hypoalbuminemia, in such patients and not tolerating fluid, this fluid can be used. In Surviving Sepsis Guidelines 2021, the last and latest, they said that in septic patients who needs large volume of fluid to maintain blood pressure, we should use albumin. So, after that, hydroxyethyl starch was widely popular before 2 decades. What should we use? What should we do? Harmful. European Medical Guidelines says in 2013. And then 18, they have published very important guidelines that strictly avoid this molecule in sepsis, burns, critical patient because of the risk of AKI and mortality. What is the conclusion? Where should we use it? Answer is that definitely not in medical ICU. In patient with surgical blood loss, it is used for just first 24 hours. So this is what is the conclusion. So finally, crystalloid versus colloid. What are the current evidence says? The 30,000 reviews, 69 studies, Cochrane data review says that crystalloid is preferred over colloid. European guidelines 2019 says that crystalloid is preferred over colloid. Surviving Sepsis Guidelines 2021 says that crystalloid is preferred over colloid. So there is no doubt that the conclusion is that crystalloid is preferred over colloids in fluid resuscitation. The primary treatment should always start with the crystalloid. No currently indication exists for routine use of colloids for treatment of resuscitation or hypovolemic shock. Colloids are potent, use it selectively in hemodynamically unstable patient, septic patient, large volume, which are not manageable with crystalloid, you should use it. So 2023 says that crystalloid is in and colloid is out. So out of 4 players, now we have only 2 players. So all of you, I request you to choose the player of your choice. That now, which one out of those 2 will be the winner? So the bases are again physiological basis, and then after crystalloid versus colloid, this is the saline versus balanced fluid. Battle between the best. Both are very good. We are using very regularly. First physiological basis, that how do we select one fluid over other? See, if we say normal saline, is it normal? No. It's a normal saline as mentioned in many of the literature. Why? Because as compared to normal composition, the chloride which is not normal chloride is 100, the saline has 154 milliequivalent. And second thing, there is no buffering effect of this fluid, and therefore, while normal saline is harmful and is labeled as abnormal saline, because of the hyperchloремia, it leads to hyperchloремia is dangerous. The side effect, ill effects are what? Acute kidney injury, decreased urine output, metabolic acidosis, hyperkalemia, and others. Against that, what is the physiological status of Rinder's lactate? It's good because the sodium, potassium, chloride, everything mimics to that of normal serum electrolytes. So it's more physiological. Not only that, the lactates get converted into bicarbonate and correct acidosis. And because of this reason, it is more beneficial as compared to that of normal saline. But these are the physiological basis. On physiological basis, colloids were better, but we didn't select it. On evidence based, crystalloids were better. So, what is the current status of saline versus balanced fluid? What is the evidence? It's a real fight. Lot of literature, lot of newer things, newer studies. So there are 2 rounds of fight in crystalloid normal saline versus balanced fluid. So first we will say that normal saline is better. So what are the evidence do we have? See, it's number 1 fluid used worldwide. Even if you see USA, only in USA more than 200 liters of normal saline are used annually. Normal saline is used by default in any of the emergency units, in any of the ICUs, emergency wards in world. And it's easily available, low cost, compatible with blood, and therefore is preferred. There is the evidence. There is no evidence. There is no study. So saline is better than balanced fluid. These are the assumptions. These are the practice. If you want to get paper done in municipality, you have to pay 100 rupees not, 500 rupees not, is a practice, but it is not a right thing, and therefore we don't have any evidence. So second round is that the balanced fluid is better. Then do we have any evidences? Answer is that long list. These are the 4 major trials which was before 2014. Then subsequently in 2015, we had a split trial which says that normal saline is better. Very, very big, 15,000 USA trial, smart trial, a game changer trial, a very important proven trial which says that with balanced fluid, there is lower rate of death, renal replacement therapy, persistence of the renal dysfunction, and therefore is preferred. So conclusion is what? Rinder's lactate is the first line therapy. With normal saline, no clinical benefit, no physiological benefit, no major cost benefit, and there may be harm. That means it's harmful. It should be valid. Ek saras majano padio bodavi rakhe. This was the past because it has a disadvantage. Answer is no. See, there are literature that IV normal saline, not too much, not too big, only for healthy kidney is good. RL is equal to normal saline, both are equally effective. Which study says? Answer is that study in 2021. Basic trial says that both are equal. Anything more? Answer is that yes, in 2022 we do a plus trial, which says that both are equally effective. So, the final word in 21 and 22 two studies says that both are equal. So, what is your conclusion? My conclusion is that it's a confusion. So, when there is confusion, I would like to let you know your opinion that run in one match was century. But whether it is important or average run rate is important. Average run rate is important, and therefore comes the breaking trials after these studies, which is a systemic review and meta-analysis. See, systemic review and meta-analysis is like average run rate. And what is the 2022 studies in NEJM and other reviews such studies says? Answer is that balanced crystalloid reduces mortality. Balanced crystalloid reduces mortality and AKI and sepsis. And therefore, this January 22 systemic trials, April 22 systemic trials definitely favors that we have balanced fluid, which is a preferred fluid. Remember, no trial suggestive of superiority of normal saline over Ringer's lactate. Some of the trials says that yes, both are equal, but not superior. Again, and additionally, if you look at the surviving sepsis guideline 2021, it says that surviving sepsis guidelines, which was previously released, says that both are effective. But categorically in 2021 surviving sepsis guidelines says that balanced fluid is better. September 2022, Korean study, balanced fluid are preferred. November 2022, Canadian study says that balanced fluid is better. And therefore, I will conclude my talk that what is the trend in 2022? What are the guidelines in 2022? First statement, normal saline is not the first fluid of choice. Use it selectively. Balanced fluid like Ringer's lactate and Cavilite is the most favored first-line therapy of choice for resuscitation. I will take 1 minute more, so there will be, I will be permitted. Okay. But now, final conclusion is that resuscitation means Ringer's lactate. But no ideal fluid exists. All fluids can be good, all fluids can be bad, and therefore, when you are planning the fluid administration, individualize based on history, dose, electrolyte, and acid status. Acidotic patient should always receive balanced fluid because it provides bicarbonate. And patient with alkalosis, hypochloremia, like vomiting, metabolic alkalosis, should always receive normal saline because it is preferred. So, normal saline has definitely role in our practice in vomiting, hypochloremia, treatment of metabolic alkalosis, hypovolemic hyponatremia, diabetic ketoacidosis, brain injury, stroke, with blood transfusion, with ceftriaxone. So, to conclude, crystalloids are preferred, always are. In second stage, amongst all crystalloids, think of Ringer's lactate, balanced fluid first, and think of normal saline as some of the selective thing. If you like this trailer, this was a trailer. The movie will be on 27th of January at API.com, where I am going to talk for 4 hours on fluid therapy in clinical disorder, in medical disorder. So, it's going to be a huge feast because talking on this subject for 4 hours will be discussing each and every important part of the story. So in the evening, in our special guest was saying that the sale more than 10,000 is a successful book, but our fluid therapy book has crossed the sale of 100,000. I would like to thank all of you for giving this opportunity to me. I don't think that the people who has heard me before almost 18 years, when for the first time this group has started installing this academic activity. At that time I had the opportunity to talk on this subject. Even after a couple of, more than 1.5 decades, I am again back here. But if you think that I am talking good, my learning phase was started with this same activity. I am so happy, and therefore I will thank you again, everybody. And one more take-home message, that I have a team of 100 nephrologists with me. All of us together have prepared kidney education website, where 200-page kidney book is available free in 40 different languages. It's a world record award winner website, received more than 10 crore, more than 100 million hits, and it's free access. So, and it's without any pharma involvement. Website with 10 crore hits is without any advertisement. I wish all of you to spread information about this website, because the two love of mine, one is fluid electrolyte and second is kidney education, and both are very close to my heart. Thank you very much again.
Good evening all. So I know you are eagerly waiting for the last lecture, so I will finish it in short, 10 minutes. Just bear with me. So in this slide, one is macroscopic hematuria, one is microscopic hematuria, but you can say that both are not hematuria. One is normal sample and one is just pseudo hematuria. So this can be called as hematuria and this cannot be hematuria. So my objective of this presentation is to define and classify hematuria, to find a rational approach to diagnosis, and to how to effectively use the labs and imaging tests. So a hypothetical case, a 40-year-old female who was undergoing her regular yearly maintenance health checkup, and she was found to have +2 blood on dipstick examination of urine analysis. Rest all findings were negative. So what is the definition? So by definition it is 2 out of 3 samples should have more than 3 RBCs per high power field, or +3 on blood on dipstick. So +2 was not hematuria, +3 has to be there, and or visibly red urine. So this American Urological Association guidance says that if you find a single sample of hematuria, you have to prompt further investigation, because the detection of cancer in these patients is as high as 3.6%. So you have, even if one sample has hematuria, you go for further diagnosis. So take home point number 1 is positive dipstick for blood should also get microscopic confirmation. Just don't rely on the positive dipstick. So not all red urine is hematuria. It can be hemoglobinuria, myoglobinuria, bituria, any medications, or porphyria. Hematuria has different types of classifications. It can be according to gross hematuria or microscopic, according to the timings, that is early hematuria which is seen in urethral origin, or terminal hematuria which is the pathology is in the bladder, neck, or prostate. According to the site of origin arising from kidneys, it will be called as nephrogenic, and from the rest of the tract it will be urogenic. Pseudohematuria is arising outside the urinary system, like menstruation. It can be further classified as painless or painful. Painful is in stone, or sometimes in pyelonephritis. Painless in malignancy or glomerulonephritis. Transient or persistent. Isolated or along with proteinuria is present, that is in glomerulonephritis. Again, glomerular, non-glomerular is same as the locations. So back to our case. So her urine was only 2+ positive in dipstick. So if we want to further examine, we have to go for the microscopic examination, as we can let it not consider as hematuria. But if we are going ahead, what would be the next step? So history and physical examination, other blood analysis, and the sonography and referral for cystoscope. So why history? So age is the most important factor. All the causes of hematuria in less than 50 would be benign. We won't suspect malignancy. If it is accompanied by urinary symptoms such as obstructive, irritative, pyuria, then we can think of UTI. If there is pain, we can think of nephrolithiasis. If there is recurrent UTI or recurrent this upper respiratory tract infection, it can be a post-streptococcal glomerulonephritis or IgA nephropathy. These are some red flag signs. If they are present in the history, you can directly jump to the diagnosis of malignancy or suspect malignancy, like smoking history or exposure to chemical or dyes, or history of gross hematuria or persistent irritative symptoms of urine, or there is irradiation or analgesic abuse. So again, physical examination is of utmost important. Fever will lead to diagnosis of pyelonephritis, hypertension if it is there, then glomerulonephritis, any heart murmur, then it can be endocarditis and septic emboli of the kidney which leads to infarct in the kidneys. Any abdominal masses can be cancer or abdominal aortic aneurysms. If there is brood, then renal ischemia. If there is edema in the extremities, there will be protein loss accumulate, so it is glomerulonephritis. If there are nodules, then cancer, or tenderness, then prostatitis. And if there can be exposure to trauma or recent exercise, recent travel to African countries such as will cause you may suspect schistosomiasis. You have to ask for family history for polycystic kidney disease or sickle cell disease and any exposure. So take home point 2 is most serious hematuria is going to be because of only these 3 reasons: infection, stone, and malignancy. So now after knowing the history, you will make the diagnosis. So I will ask you 4 cases, you tell me the answer. A 7-year-old boy presents 2 weeks after an episode of pharyngitis because his mother noticed his urine was red and he has mild edema on the examination. So what would be the diagnosis? So it is just So a 50-year-old man presents with 1 week history of pelvic discomfort, urinary hesitancy frequency, that is he is having low urinary symptoms. He has a fever, he has a tender prostate, he does not have any pus cell in urine, only RBC in urine. So that from the history only you can come to the diagnosis of prostatitis. A 28-year-old man presented to ER with severe flat pain that is radiating to the ipsilateral groin. So now he has pain, he is sweating, he is nauseous, he is severe pain. So from the history it's very clear you suspect urolithiasis. And last case, a 38-year-old with chronic pelvic pain, now presents with macroscopic hematuria. She has no other symptoms, and she tells that her urine is dark only after the menstrual cycle. So most likely diagnosis is endometriosis. So take home point 3 is look for typical cluster of symptoms and signs, and that will lead you to the diagnosis. But what if I don't have an easy diagnosis? What next if history and physical examination is not coming to diagnosis? Then you have to get back to the microscopy. So in microscopy you have to determine whether it is coming from kidney or coming from rest of the tract. And how do you do it? By seeing the RBC. So if it is coming from kidney, then the RBC will be dysmorphic or it has changed its shape. And if it is coming from rest of the tract, it will be isomorphic. So this is dysmorphic RBC. If you see the shape is not proper, there are agandocytes, and this is isomorphic RBC, which will be seeing if there hematuria from the rest of the tract. So if you diagnose it as glomerular, go for renal biopsy. But biopsy is indicated not only means if it is indicated if it is accompanied with proteinuria. Just for hematuria, we don't usually go for renal biopsy. And if it is from non-glomerular, means isomorphic RBCs, then you suspect some urological diagnosis. So step 1 is CT scan, CT IVT, but it may miss small lesions. Step 2 is cytology, but if you want to go directly, go for cystoscopy, which will help you in diagnosis. So this is just for fun. If all these things don't come and don't continue your diagnosis, then you can rest assured the patient that the hematuria is not causing any harm, so let it be, or you can refer to a chiropractor. So what we have learned is you have to do a microscopic confirmation. You have to decide whether it is glomerular or non-glomerular. Top 3 suspects are infection, stone, and malignancy. And if it is non-glomerular, you can after CT directly go for cystoscopy. So this is a complicated way of reaching to the diagnosis. Thank you.
And the task given to me was to talk about approach to patient with resistant hypertension. As you all know that hypertension is what we deal with day in and day out. It's a rare patient of kidney disease who does not have hypertension. And we do see a lot of patients with hypertension. We'll see what we can do about these patients. So to start off with the start of that case, the 52-year-old software engineer is referred to you for further evaluation of his blood pressure. He is hypertensive for 12 years and diabetic for 5 years. His current complaint includes fatigue and dry mouth. His medication include telmisartan 80 mg, nicloprid, Fitard 20 mg twice a day, hydrochlorothiazide 25 mg once a day, clonidine 0.2 mg twice a day, metoprolol 25 mg twice a day, atorvastatin, metformin and ibuprofen. So it's a good remarkable family history except both parents are hypertensive. His seated blood pressure is 156 by 94 and heart rate is 72 beats per minute. Examination is under mark except grade 2 hypertension and his renal analysis is normal. So what do we understand by resistant hypertension? So essentially the definition of resistant hypertension is defined as blood pressure remaining above the target blood pressure despite using 3 antihypertensives in appropriate doses including the diuretic. So they are the maximum tolerant doses and a diuretic is included in that. Furthermore, if you require 4 drugs to reach the target blood pressure, then also it is known as controlled resistant hypertension. So essentially patients requiring more than 3 drugs including a diuretic, but they are not controlled, then they are resistant hypertension. So what is the prevalence of resistant hypertension? It depends upon the practice where you are. It is about 1 to 30% in the general practice, but more than 50% in nephrology practice. We see nephrology, most of them require 3 to 4 drugs to manage their blood pressure. And in the US, the data suggests about 8.9% of the patients with hypertension have resistant hypertension. Why it is important to control blood pressure? Because if you see even a 2 millimeter reduction in the systolic blood pressure leads to about 7% reduction in ischemic heart disease and mortality, and also a significant reduction in the stroke. So it's important that every reduction of millimeter blood pressure is important for the patient for preventing complications. Now there are 2 things to realize is that whenever we measure the blood pressure, is it truly hypertension resistant or not? So we try to take step-by-step approach to approaching the patient with resistant. The first thing is to confirm that the patient is truly hypertensive. And these are the situations where there is a role of ambulatory blood pressure monitoring. Now it is very widely available and a lot of industry is also supporting the use of ABPM. So you can put your patient to ABPM and measure out truly whether the patient is really having hypertension or not. There can be 4 groups can be there. That is truly normotensive, that both the office as well as the ABPM are normal, there is normotensive. And give it 2 hypertensive and both the office as well as ABPM are abnormal. And what can be white coat hypertension is in the clinic that they have hypertension, but in ABPM they do not have hypertension. And a masked hypertension is in clinic they are normal, but ABPM is showing this hypertension. So ABPM is a good measure to know the 24-hour blood pressure control, and if they are really hypertensive, these are the patients which we need to target for treatment. Second important thing is you all very well know, it is repeatedly told, but always make sure that you measure the blood pressure in the most appropriate way, that is in the sitting position. Make sure the cuff size is appropriate and take care the blood pressure is measured appropriately. Third thing, what you need to do for this is that easier said than done, that is lifestyle management. Salt restrictions are key, and I think nothing more, but you repeatedly emphasize that. Weight loss, make sure the patient is adherent to the treatment. Our patient is possibly adherent to the treatment because he's got dryness of mouth telling that he's probably taking the clonidine drug. His heart rate is 70 telling that he's probably taking his beta blockers also. So there are clues to tell you whether the patient is taking the medication or not. Sometimes the situation where they're not taking, you may do the drug studies in the urine or in the blood, not very popular in our country, but you can really ask the diary and see whether they're taking the medications or not. And another important suboptimal dosing, that many times we use smaller dose of multiple drugs, 10 mg of telmisartan, 20 mg of telmisartan, with a very small dose hydrochlorothiazide 6.25 and 25 mg of metoprolol. Combinations like this are not to be used. Use an appropriate dose to make sure the patient is responding or not. So what about the evidence to show that salt restriction is still useful? This is a very small study, and it was a randomized trial for 12 patients who were resistant hypertension, and they were put on a very, very low salt diet. That is 50 millimole. 50 millimole would translate about 3 grams of salt per day, and a normal diet is about 250 milligrams, about 10 grams of salt per day. If you do that, then the blood pressure reduction can be anywhere from 20 to 9 millimeter reduction in the systolic blood pressure you can achieve if you do just salt restriction. But you have to really repeatedly emphasize that salt restriction has to be done. And these are trials to show that it is still useful when patients have resistant hypertension. The other important thing which many times we forget is the obstructive sleep apnea. A lot of obesity is now if you see. And one of the important drivers of hypertension obstructive sleep apnea, as can be shown in this study, that in resistant hypertension, a significant number might have obstructive sleep apnea, and which is now amenable to treatment either by the use of a BiPAP or some other mechanisms. So it's important. Another important thing to note is that a lot of drugs will interfere with the control of blood pressure. And the top number is NSAIDs. A lot of patients have osteoarthritis, they are on NSAIDs, and that is the number 1 drug which will interfere with the control of blood pressure. Erythropoietin is not important in our practice, in your physician's practice, but oral contraceptive is important. And some of the psychiatric medications especially can be important. Also cough and cold medicines can be important. And recreational drugs. Now, sedative use is increasing, so we should not forget that. A lot of people are taking drugs, especially people coming from Punjab and some of this area which we see are used to take a lot of drugs, and it can cause also interfere with hypertension. Another important, once you have ruled out the basics of all things, you must not forget that resistant hypertension patients can have secondary hypertension. So this I just put it, but I will not go through the whole algorithm, it will take a lecture by itself. But most important one is the primary hyperaldosteronism. Increasing evidence is being shown that patients of resistant hypertension might have a primary hyperaldosteronism. And the important clues are hypokalemia or metabolic hypertension is important clues. And even if they don't have that, but they have resistant hypertension, it is mandated with all these patients who have aldosterone PRA ratio done. And if this ratio is higher, it will tell you the patients have primary hyperaldosteronism. It can be investigated further, either require surgery or a therapy. Of course, as nephrologists, we always look for endovascular disease. And if patients have got hypertension at a younger age or at an older age group, flash pulmonary edema, unequal size kidneys, or if there is a Doppler finding to suggest that there is an increase in the velocity, you need to control for that. Look for endovascular disease. Similarly, pheochromocytoma, as you all know very well, parenchymal disorders, look at the creatinine. Sleep apnea, we already talked about. Coagulation of aorta, make the blood pressure in the upper limb and the lower limb, and also make sure that we are able to correct it. And of course, some other endocrine causes. So don't forget secondary factors. Then coming to the meat of the top, it is what about the pharmacological treatment? That once you've done all the basic things, that the classical teaching is that all patients of hypertension, if they should be treated with 3 drugs, that is combination of an ACE inhibitor or an ARB, calcium channel blocker, and hydrochlorothiazide. The key thing, that question that now comes up, which should be the 4th drug in your armamentarium. So whether it should be an alpha blocker or a beta blocker or increasing the further dose of diuretic, or what drug should be added to the 3 drugs that we classically put all our patients on. So the question is that which of these 3 drugs we should be using, the vasodilator drugs, and let's see what is the evidence to all this. So this was an older trial, an ASCOT trial. ASCOT trial was a trial in patients who had resistant hypertension. They are requiring 3 drugs. This was an open label trial, so it's not a controlled trial. So 1,411 patients were assigned to the trial of 25 mg of spironolactone. And if you can see, there was a significant reduction in the pressure to a tune of about 20 millimeters of systolic blood pressure and about 10 millimeters of diastolic blood pressure. So the 4th drug in the ASCOT trial told us that if you use aldosterone antagonist, there is spironolactone only given 25 mg of that is not matters and control the blood pressure. Then came another trial which was the Pathway 2 trial. Pathway 2 trial actually looked at it, which of the 4 drugs one should use. And let's see the trial. So they had patients between 18 to 80 years of age, blood pressure more than 140 in the clinic and 130 more than 130 in the home. And they were already on 3 drugs, that is the calcium channel blocker, ACE inhibitor and diuretic, and for 3 months, and they were still not controlled. So what the trial investigators did was that they used the drug in rotation. For 12 weeks they used spironolactone, then they used doxazosin, then they used bisoprolol, and then they used a placebo. So like that they rotated the 4 groups, the 4 drugs, to see which one is the most effective therapy. And if you can see, so this is the trial just to show you. So the most effective therapy was found to be against spironolactone, and they found that it was most effective compared to doxazosin and bisoprolol. So right now the recommendation is that 4 drugs should be spironolactone, which is an aldosterone antagonist. And which are the patients which are best likely to respond? So we did a sub-study of this study, and those patients who have, of course, low renin, they are more likely to respond to spironolactone compared to if they are not high renin. And most of these hypertensive patients eventually might have a low renin, and they might have a slight hyperaldosteronism, and this drug works wonderful for them. So in conclusion, spironolactone is the most effective adult therapy for treatment of resistant hypertension. However, both doxazosin and bisoprolol are superior to placebo, and it could be good choices when spironolactone is contraindicated. So if you're not able to use spironolactone for some reason, then one can use that. We have got a newer, that is eplerenone, can be equally used, which has got some lesser side effects. But the previous drug, which was eplerenone is also a middle body receptor antagonist, but it has got a very poor antihypertensive effect. It has a good protective for the cardiac and the renal, but a poor antihypertensive effect, so it is not to be used for hypertension control, but otherwise it's a good drug. There is another drug which is known as exacerone, which is being in development like eplerenone, which has got a good antihypertensive effect, but that drug is available, has got lesser side effect compared to spironolactone, and maybe that drug might make a way. But otherwise it could use bisoprolol or doxazosin, any of the alpha blockers, especially low renin to support HCUs. So sometimes it is very difficult. You do what you may at the blood pressure just doesn't come under control. And this is what I call as a bomb therapy. It's like carpet bombing. So you put the patient on minoxidil, which is a very, very important peripheral vasodilator. You can't beat minoxidil in its degree of peripheral vasodilation compared to nifedipine, amlodipine, anything you take, minoxidil beats all of those. But the problem with minoxidil is that it will cause tachycardia because it's a peripheral vasodilator and it causes fluid retention. So you will see a lot of these patients with edema. So important is always do it with a beta blocker and a diuretic. Don't use minoxidil alone. If you use alone, patients will not be happy and will not be successful. So if you use this therapy, there is a rare patient who does not respond. Okay? So in case of situation where you have this, you can use this therapy. And then there are now new things that are coming, a device-based therapy, as you all must have heard about it. These are the efferent sympathetic system has significant effect to maintain the blood pressure, and these the sympathetic nerves, you can ablate those nerves. And they cause increase in the renin secretion, increase in tubular sodium absorption, and also increase in alpha A1 beta receptor activity, and they can all increase the blood pressure. So what you can do is you can ablate those nerves. However, the randomized trial, the Simplicity 3 trial, I am not going into details, but it was actually a negative trial. But there are certain small group of patients who don't respond to anything. One could consider using the device-based therapy. It is making a comeback. The technology is getting better, and maybe it may have a resurgence for a role in control of hypertension. There's another thing what is known as the baroreflex activation. That is, what you do is that you do a carotid stimulation. When you do a carotid stimulation, it goes to the brain, and then from the brain it sends messages, that is the alpha blockade, and you can get reduction in the blood pressure. Again, there are small trials to show it is useful, but still not very available in the popular parlance. So what did we do with our patients? So in our patients, we started with spironolactone. There was some effective reduction in the blood pressure. We tapered the clonidine, tapered the metoprolol, and then we tried to take out the nifedipine. But we were not successful. Again, we had to introduce nifedipine again in this patient. Important to note is that when you start therapy, you have to wait for 2 to 6 weeks for the complete effect to come. Don't expect that you start a therapy and next day the blood pressure will come under control. Always wait for 2 to 4 weeks. Once the patient is well controlled, take off one drug and see. Because when you're using combination of drugs, it is likely that some drugs are working, some are not working. So you might be unnecessarily giving drugs which are not working, like clonidine. It has a lot of symptoms. And if it is not working, we'll try to take it off gradually. As you all know, clonidine should take it off gradually. You make a dose gradually and then take it off. Similarly, you can take off some of the beta blockers and see. Sometimes you're successful, sometimes the blood pressure starts going up again, you will reintroduce the therapy. So the take-home message I would like to put in the conclusion is that after the 3 drug therapy, aldosterone antagonist, that is the spironolactone remains the drug of choice, but you can use other therapies as we discussed. I would always confirm the blood pressure, that is ambulatory blood pressure. Make sure you rule out secondary hypertension and do a supervised administration of a drug, do a drug as if required, and use the most appropriate drug in the most appropriate doses. And then the rare patient who does not respond or whom we are not able to control. And then we need to refer them to a hypertension specialist who may be able to help us with that. Thank you.
I'm going to talk about proteinuria today. What is proteinuria? What are the different types of proteinuria? What are the causes of proteinuria? And how to approach to a patient who is having proteinuria. So urine analysis is very important to diagnose the kidney diseases, and proteinuria is a very important finding of urine examination. Proteinuria defines the patients with kidney disease and those at the risk of worsening kidney disease and increased cardiovascular morbidity. It is also one of the factors in the definition of CKD. Proteinuria can be transient due to a benign renal cause, or it could be fixed or is persistent due to organic renal causes. So a healthy individual excretes less than 150 mg per day of total protein and less than 30 g per day of albumin. Proteinuria is defined as urinary protein excretion of more than 150 mg per day, and albuminuria is excretion of albumin of more than 30 mg per day. This is the composition of normal urinary protein, which constitutes the 150 mg of protein. First one is 10 horsepower protein. It has the maximum content, followed by albumin, immunoglobulins, hormones, enzymes, and mucopolysaccharides. So these are the methods for measurement of urinary protein. There are qualitative methods like urine stage, in that we can get an estimate of the protein excretion in the form of we get trace or +1, +2, +3 and +4 albuminuria. Other tests are sulfosalicylic acid test and heat coagulation test. In the quantitative test, we have 24 hours urinary protein. That is the gold standard test for urine quantification. It nullifies the circadian rhythm which occurs with the protein excretion in the body. And the next is for urinary albumin to creatinine ratio or protein creatinine ratio. It is an alternative to 24-hour urinary protein estimation. It can be done on a spot sample. What are the mechanisms of protein handling by the kidney? The normal protein excretion is affected in the place of glomerular and tubular mechanisms. If there is a glomerular injury, there is abnormal losses of intermediate molecular weight protein like albumin, and in tubular injuries, in tubular interstitial disease, there is increased loss of low molecular weight proteins. This is the classification of proteinuria. First is functional, it is divided into transient and orthostatic, and the persistent one are glomerular, tubular and overflow proteinuria. First we will talk about functional proteinuria. It is a benign form of proteinuria in which the protein excretion is more or less than 1 gram per day. It is divided into two parts, a transient proteinuria and orthostatic proteinuria. So, if the deep stick analysis shows 0 to +2 proteinuria, but subsequently if it is negative, then we can assume that it was a transient proteinuria. The potential triggers for transient proteinuria are acute illness, fever, exercise, urinary tract infections and heart failure. It is assumed to be hemodynamic in origin and it is transient. After the potential trigger has been resolved, the repeat urine protein estimation is found to be normal. Next is orthostatic proteinuria, which is seen in adolescent and young adults in 3 to 5% of cases. In this condition, there is increased protein excretion in the upright position, but there is normal protein excretion when the patient is in the supine condition. So for the diagnosis of this condition, we have to get split urine samples. That from morning 7 a.m. to 11 p.m. sample and then from 11 p.m. to 7 a.m. sample. So in that the morning sample will show proteinuria, but the night sample will be normal. The daytime sample has increased concentration. In this condition, there should not be any hematuria or hypertension. Next is the pathological proteinuria or the persistent proteinuria. It is divided into 3 types, glomerular, tubular and overflow. The glomerular proteinuria is due to increased capillary permeability due to effacement of epithelial fold process and disruption of glomerular basement membrane. There are primary and secondary glomerular nephritis. We will be seeing the causes subsequently. The tubular proteinuria is due to decreased tubular reabsorption of filtered protein seen in tubular interstitial diseases. The overflow proteinuria is due to increased production of the low molecular weight protein like light chain proteins. In leukemias, lysozymes are seen in lymphomas. So the renal tubule, they are not able to absorb this protein and there is overflow of protein in the urine. These are the causes of proteinuria. In the glomerular, we have primary and secondary causes. In the primary, these are the 5 diseases which we see frequently: minimal change disease, membranous nephropathy, FSGS, membranoproliferative glomerulonephritis, and IgA nephropathy. In secondary causes, we have diabetes mellitus, collagen vascular diseases like lupus, amyloidosis, preeclampsia, and certain infections like HIV, HPACT, and CV. In certain type of cancers, we have secondary membranous nephropathy, secondary FSGS. Then it can be seen when the patient is on certain drugs like NSAIDs, penicillamine, lithium, heavy metals. In tubular causes, there is hypertensive nephrosclerosis. Tubular interstitial disease includes acute interstitial nephritis, Fanconi syndrome, patient with sickle cell disease, patients taking antibiotics and NSAIDs. In tubular interstitial disease, the proteinuria is generally less than 1 gram per day. Overflow proteinuria, the causes are hemoglobinuria, myoglobinuria, multiple myeloma, amyloidosis. So these are the common glomerular diseases which presents as nephrotic syndrome in adults. We can find minimal change disease, FSGS, membranous nephropathy, MPGN, type 1 and type 2, cryoglobulinemic membranoproliferative glomerulonephritis, and the secondary diseases are amyloidosis and diabetic nephropathy. They are the most common glomerular disease presenting as nephrotic syndrome in adults. So proteinuria has some consequences. It can cause hyperlipidemia, hypercoagulability, increased susceptibility to infections. Patients may have peritonitis, urinary infection, cellulitis. There is risk of AKI due to proteinuria and due to the use of diuretics and the antiproteinuria drugs that we use that can cause AKI. And there is also risk of chronic kidney disease. So how to approach to a patient? The first and foremost thing is history. We cannot replace history and physical examination in any of these diseases. If it is asymptomatic, the proteinuria is detected during the routine screening. The patients have symptoms, we have to ask for the duration. The symptoms include history of recent fever with sore throat, periorbital puffiness, progressing to anasarca, frothy urine, colored urine, oliguria, nausea, abdominal pain, joint pain, rashes. Past history is very important. We have to ask for diabetes, hypertension, ischemic heart disease, renal disease, systemic diseases. In the drug history, we have to ask for NSAID, cyclosporine, and exposure to heavy metals. And we have to ask for family history of renal diseases. Physical examination should include blood pressure, body weight measurement, should include edema, particularly facial, renal edema, ascites, skin examination, to look for rashes, purpura. Xanthelasmas can be seen in patients having hyperlipidemia. There could be white nails or bangs due to chronic hypoalbuminemia in patients having long-standing nephrotic syndrome. And fundoscopic examination to look for retinopathy. These are the basic investigations we should look for is complete blood count, renal function test, uric acid, protein and albumin levels, urinary dipstick, urine routine examination, and urine protein quantification by 24-hour urinary protein quantification or a spot urine protein creatinine ratio, and renal ultrasound to look for the sizes of the kidney. In certain diseases which present nephrotic syndrome like diabetic cases or HIV associated with nephrotic syndrome, the kidney sizes are increased. We have to look for any structural abnormality in renal ultrasound. So a urine routine examination, routine and microscopic examination is very important in these patients with nephrotic syndrome. If this fatty cast-free fat or oval fatty bodies are hallmark for nephrotic range proteinuria. Leukocytes and leukocyte cast are seen in patients with UTI, in that we have tubular range proteinuria. Leukocytes and leukocyte cast without bacteria is seen in tubular interstitial disease. If there is normal shift RBCs, it suggests the origin is from the lower urinary tract. And if there are dysmorphic RBCs, we have to think about a glomerulonephritis. Erythrocyte cast is also seen in glomerulonephritis, granular or cellular cast. They are seen in advanced renal disease in CKD. Eosinophilia, it is not very specific. It may be suggestive of a drug-induced acute interstitial nephritis. Other tests which we order for the patients having nephrotic syndrome are lipid profile, HbA1c, KS or titers, anti-nuclear antibodies, NCA studies, serum complement levels, HIV, hepatitis B and C, serum protein electrophoresis, and a renal biopsy. So this is the approach in a patient who is having isolated asymptomatic proteinuria. Patient is not having any symptoms. So it is just detected in the urine routine microscopy examination that patient is having +2 albumin in the urine, +2 or +3. Then we have to quantitate the protein excretion and check the creatinine. If the GFR is normal and there is non-nephrotic proteinuria, then we have to check for recombinant overnight proteinuria estimation. If the dipstick is negative for the recombinant overnight sample, then we can say that the patient is having orthostatic proteinuria and it is a benign condition. If it is a persistent and fixed proteinuria, and the patient is asymptomatic, then we can reassess the patient after 6 to 12 months with again the same things, the urine protein estimation, GFR estimation and blood pressure. If everything remains normal, we have to keep the patient in follow-up every 6 monthly or yearly. And if the GFR or the blood pressure is abnormal or the proteinuria increases, then we have to go for the serological test that I have described in ultrasound. And if we don't find a cause, then we find there is microalbuminuria, then we have to consider that the patient is having early diabetes, essential hypertension, early stages of glomerulonephritis. In the patients having microalbuminuria, the protein excretion of 300 to 3,500 milligram per day of protein. We have to consider the previously mentioned causes along with the myeloma-associated kidney disease, and we have to rule out intermittent proteinuria, postural proteinuria, and we have to look for any triggers like congestive heart failure, fever, exercise, or UTI. In case of nephrotic range proteinuria, we have to look for diabetes, amyloidosis, and minimal change disease, FSGS, membranous glomerulonephritis, and IgA nephropathy. If the patient is having active sediments in the form of RBC or RBC cast on urine, then we go for the serological test as described previously, like anti-GTM antibody, anti-CAB, ANL levels, cryoglobulins levels, anti-phospholipase beta receptor antibodies, hepatitis B and C, HIV, TSO titers. So, proteinuria is not just a marker for the kidney disease, but is also a culprit in the progression of the kidney disease. So, control of proteinuria is the most important thing to arrest the glomerular disease progression independent of the underlying etiology. Treatment of secondary causes is the treatment of the underlying causes that specific therapy has to be given, plus the supportive care. This is the supportive treatment that we give for proteinuria. Blood pressure control should be targeted to be less than 140 by 90 mm of mercury, and if the patient is having proteinuria of more than 1 gram per day, it has to be a stricter blood pressure control to less than 130 by 80 mm of mercury. Maximum use of ACE inhibitors and ARBs, and also there is a role of non-dihydropyridine calcium channel blockers. They are also showing to reduce the proteinuria. Diltiazem and verapamil, they are also used as anti-proteinuric agents. In the diet, we have to advise for moderate dietary protein restriction of around 0.8 milligram per kg per day. Plus, we have to replace the urinary protein losses and carefully examine the nutritional status. For the edema management, we have diuretics and sodium restriction. We can also give albumin in selected patients. Glycemic control is very important. HbA1c target should be less than 7%. In diabetic nephropathy with proteinuria, SGLT2 inhibitors, they also have role in reducing the proteinuria. Lipid control is also very important. Statins can be used. The indications are the same. If the lipid levels are high and the patient is at the risk of cardiovascular disease, then we start the patient on statin. Treatment of hypercoagulation. So, it is recommended if the serum albumin level is less than 2 gram per deciliter, then patient has to be started on anticoagulation in the form of warfarin or NABH, because these patients are at higher risk of having thromboembolic disease. And also specific immunosuppressive therapies depending on the glomerular disease that is detected, like in minimal change disease, and FSGS, we give steroids. In membranous nephropathy, we give modified Ponticelli regimen, and accordingly as per the glomerular disease, we give the specific immunosuppressive therapies. Thank you.